Evaluating a case of secondary tuberculosis. Inhaling the aerosolized droplets from an infected person is the principal mechanism through which tuberculosis spreads. Any patient suspected of active tuberculosis is a public health risk for transmission and should be isolated with airborne precautions. After primary infection, 90% of individuals with intact immunity control further replication of the bacilli, which may then be cleared or enter a latent phase. The person remains asymptomatic, but latent disease has the potential to become active at any time. In a small percentage of patients, the initial infection progresses and manifests as rupture into pleural space, causing tuberculous pleurisy, extensive caseous pneumonia, enlargement of tuberculous lymph nodes, resulting in bronchial obstruction, rupture of TB focus into a bronchus, leading to endobronchial tuberculosis. The risk factors causing breakdown of previously healed lesions are malnutrition, alcoholism, poorly controlled diabetes mellitus, silicosis, immunosuppression by disease or drugs, postpartum period, post-gastrectomy, and jejunal bypass surgery, chronic hemodialysis. History. When the clinical suspicion is high, further history should be obtained, evaluating for risk factors of active tuberculosis. History of HIV infection, degree of immunosuppression, influences the clinical manifestations. History of prior tuberculosis treatment. History of a positive, purified protein derivative of the Tuberculin Test result. Contact with a person who has active TB. Clinical presentation. The presentation of secondary tuberculosis is different from that of primary progressive disease, as the hypersensitivity and tissue reaction is more severe in secondary tuberculosis. The following symptoms may be noted: prolonged cough more than 2 weeks, sputum production, chest pain, shortness of breath, hemoptysis. Constitutional symptoms such as fever, night sweats, weight loss, anorexia, fatigue are often present. Physical examination. On inspection, note the type of chest retraction or limited expansion on one side, bulging of the chest as effusion, and empyema, scars, enlarged glands, atrophy of muscles, curvature of spine, and clubbing of fingers. On palpation, you may detect apex beat, heart thrill, rigidity of muscles, an increase or decrease in tactile fremitus. On percussion, you can notice slight impairment in resonance to dullness, flatness, or tympany. On auscultation, look for prolongation of expiration, pleural friction. Persistent fine moist rales after the expiratory cough are generally due to tuberculosis. The following investigations should be made: chest X-ray, sputum examination, Tuberculin Test. Chest X-ray findings. Primary tuberculosis is said to be characterized by lower lobe disease, adenopathy, and pleural effusions, and termed atypical, whereas secondary or reactivation tuberculosis is associated with upper lobe disease and cavitation. Sputum examination, at least thrice by concentration method, for acid-fast bacilli by Ziehl-Neelsen technique, when bacilli are numerous, or auramine phenol fluorescent test, when bacilli are small in number. For sputum positivity, there should be a concentration of more than 50,000 bacilli per milliliter of sputum. The tuberculin skin test is one of the most valuable tests for demonstrating tuberculous infection in both symptomatic and asymptomatic. A standard dose of 5 tuberculin units, 0.1 milliliter, is injected intradermally into the skin and read 48 to 72 hours later. A person who has been exposed to the bacteria is expected to mount an immune response in the skin containing the bacterial proteins. To get more such high-yield medical content, don't forget to subscribe. BasidiaMED. The easiest and fastest way to take advanced clinical history.